in 48 hours, steroids, whatnot, ICS LABA combination. I said, you use it regularly and see me after 4 weeks. And then I miss her. I don't see her at all. I see her 6 months later, same bed, same exacerbation, same drugs. And I look at her and ask her, I asked you to take your drug regularly. What happened to that? You know what she told me? She said, doctor, you told me what will happen if I took the drug. You didn't tell me what will happen if I didn't take the drug. It sort of opened my eyes, like the way patients look at things. They look at best case scenario and worst case scenario and then try and figure out something in the middle. And I think that's something that we can tell them. We can tell our patients, you need to be regular with therapy. If you're regular with therapy, you'll be here. If you're irregular with therapy, you'll be there. And if you want to be elsewhere, that choice is yours. So I think we need to get this message across to patients. That's because we're not talking to them. That's really what it is. It finally boils down to this guy who's sort of pathetically sort of proclaiming things while I do a lot of other things other than that. Relentlessly stress the need for continuous therapy. So it's important that in any of this, especially in a situation like pneumonia, that you talk not only with the patient, but also with the patient's relatives. And I think this is very, very important. A word with the relatives will mean a huge thing for you as such, not only for you, but for them as well, and for the patient as well again. So we've looked at pneumonia in a lot of these aspects, and we've picked out a few things here and there which can tell us how we can avoid non-resolving pneumonia in the first place by doing simple things like a white cell count, a gram stain. Keep repeating the white cell count and keep repeating the gram stain, even do a culture as quickly as possible. Don't assume an organism unless you have one. Pneumonia is a very nice thing to treat. It's extremely rewarding to treat provided you hit the bus right. That's important. You need to get into the right bus to get into the right destination. We need to understand that as well. So we will just say that the possibility of an untreatable infection appears alien to the physician of today. We sometimes find it very difficult to comprehend. We have a sensitivity which shows every resistance to every single antibiotic available. You're willing to sort of pull your hairs apart, But I think this is a stark reality that is staring us in the face. But if current resistance trends continue, this will become a reality. Thank you for the patient listening.
Thank you, sir, for a wonderful lecture. To say a person quality look at his company. Sir uttered the word of background. At least he uttered the word of background 10 times. So before approaching any unresolved pneumonia, look at the background. I think this is a very good message. The thing is, I recently read from one journal that we are talking about the bugs, resistant bugs and everything. Then one man retorted in a big way. See, this I read from the Sexual Times of India has come. The germs do not cause disease. Why do you blame germs? Because doesn't God know that He has balanced everybody's life, He created man, animals, everything. He has created germs too. So I just need an answer from sir. Germs do not cause disease. Nature never surrendered her children with enemies. It is the individual himself who makes disease possible in his whole body because of poor living habits, poor dietary habits. Actually, bacteria are our symbiotic partners in both health and disease. They serve a useful role as scavengers. They make harmless and remove undesirable substance within our body. I need an answer from you, sir.
I think if you read the Bible, it will say God created heaven and earth in 1 week's time. God created everything. He created the antibiotics as well. What we need to make sure is we need to use these things right. That's really what it is. All confusion that mankind has gone through over the past so many years, the world wars, and everything is man-made. We understand that. We understand that everything is man-made. Nothing exists that is not man-made. There may be some natural calamities occurring here and there, but most of the problems have been created by us, and we need to sort of rectify them. And if we need to rectify them, we need to make sure that we use our resources properly and prudently for that matter. And I think that's really the key. The key is that bugs are there, a bad situation is there. Agreed, we have created a lot of bugs and we have created a lot of resistance. I would be the first to put my hand up and acknowledge that. But I will also acknowledge the fact that we have a thing called antibiotics which we can use and use them frugally and prudently and make sure that we're able to overcome this. After all, God created everything, including you and me.
In your experience, how many cases you have seen viral pneumonitis? Because we don't do any workup for virus. We do mostly for bacteria. And most of the time we treat only bacteria, thinking all the pneumonias are caused by bacteria, and we think virus don't even exist. So, your opinion, sir?
The question really, I think, would be that, do you have the guts in a patient who has a chest patch and a total white cell count of, say, 6,500? Do you have the guts to leave him without an antibiotic? I don't have the guts. I don't know if Patabi has. I don't know. I don't have the guts. I'd give him rather something rather than anything. You're fully right. He could be viral. Absolutely. The question there would be, create as little harm as possible. Don't jump on these antibiotics. Don't jump on the antibiotic. If you have a white cell count which is reasonably normal, keep your antibiotics 3 S's, simple and straight. Very important. You keep it very simple and very straight, and don't go for the complicated stuff at all. In fact, if it's possible not to prescribe antibiotics and wait for some time, please wait. You'll find that more than at least 50% of them will sort of resolve by themselves. You don't really need to do anything beyond that. The question really is there an indication to go for something which is big, and after that you'll get it bigger and biggest, and finally you won't have anything left? That's really the question.
HSCRP is positive in coexisting diseases also. How can we correlate with this particular thing?
No, I think the HSCRP, as I said, is not an absolute indicator or an absolute marker. It is just a sort of adjuvant guide to tell us whether we have tackled the infection properly at all or not. A falling CRP probably is evidence of a falling infection as such, if you want to pick the organ. But as I said, a CRP will not be better than a simple white cell count for that matter. And I somehow get the very strange feeling that we're not doing enough white cell counts. Like you have a white cell count of 20,000, he goes out of hospital without another white cell count at all. The simple things that we are not really going to say. I still remember my teacher, Professor Nanjad Rao, used to say, commonest things are commonest, simplest things are simplest. And we need to understand that there are simple things that we can do which will give us very good information, which will prevent us from using the sort of exhaustive medication that's really not necessary.
Sir, whether CRP can be used as a continual marker for response?
The question would be, how many times are you going to do a CRP for that matter? Are you going to do it every day? I don't think it's worth doing a CRP every day. At this point of time, I would do a CRP, but then I would not lay too much emphasis on a CRP. I would in fact lay more emphasis on a simple white cell count than a CRP today. Because all that I want to know is my infection coming down or not. If I have a COPD, if I have an index COPD with an exacerbation, whom I think is going to exacerbate, there I think there's enough evidence to say that a high CRP 3 weeks after an exacerbation is definite index of another exacerbation coming down the line. That's one place where the veracity of a CRP has been 100% proved. There are a lot of studies to tell us that, especially in COPD exacerbations.
I congratulate the speaker on his Beam-Singh approach rather than the Shankar approach on fundamentals of leukocyte count and gram stain. But I wonder how many laboratories in Trichy can do a gram stain, except perhaps the medical college. I don't think nowadays the technicians know how to do a gram stain at all.
So there is a price we pay for everything, sir. So there is a price we pay for the e-buses that he has, for example. So there is a price we pay. But the point really is, if you want to make your point, you can get the lab to do a simple gram stain for you. It's not very difficult at all. Anybody can do a gram stain. And I think these are the simpler things that we really need to work up and concentrate upon, rather than look at very high-flown stuff like procalcitonin and even CRP, HSCRP for that matter. After all, we are dealing with a simple, straight infection, isn't it? The only question is we are not able to find out what that infection is, and so we are sort of left between the devil and the deep sea.
Congratulate, sir, and thank you for your wonderful lecture, sir. Now I invite Dr. Ganapathy Subramanian. See, there is a relationship between Tirunelveli and Trichy. The man who hails from Tirunelveli, it's actually the historical things goes like this. The Nelliyappa temple in Tirunelveli, there are inscription indicate that the Lord Shiva descended in the form of hedge and roof to save the paddy crop of a devotee. Tirunelveli. Tirunelveli, that is meaning sacred paddy hedge. Tirushalapalli, Tiruchirappalli, Tiruchirappalli, Tiruchinnapalli. There are so many things in the historical thing. Sila means Silai, rock. I think probably, I don't know the historical background, how you named it. Even the bronchoscope looks like a mic actually. We have a Medi rock in our college days. So, this is the bronchoscope. Actually looks a fantastic backdrop. The man who hails from Tirunelveli, Pulmo, pulmonologist, and who chose to live by quirk of fate that in Trichy is chosen as a destination, because one life, one destiny. So I think he's growing well professionally. He's a good human being. So I invite Dr. G.S. to deliver the pearl of wisdom. Before that, see, the wisdom comes through a lot of experience, right? The physician must be big enough to admit his mistakes, smart enough to profit from them, and strong enough to correct them. At the end of the day, bad judgment gives experience. That's what the wisdom is born. The greater our knowledge increases, the more our ignorance unfolds. He's the man always believes in, Dr. G.S., that keeping the controversy on pages, not in relationship. Here are I invite Dr. G.S. to go ahead with the pearls of wisdom.
Thank you, sir, for your introduction. So, I don't want this case to be, what I learned. So it is something different I want to discuss, and it is my observation and certain things I have learned. So I want it to be a formal discussion. So this patient is Adimulam. Is a 70 years male, he is ex-law retriever. His complaint is mainly cough with expectoration, low grade fever on and off, and loss of appetite and loss of weight for 1.5 years. And he was put on ATT 2 times because of unresolved lesion. And within a short period of, within a period of 1.5 years, and he is not a smoker, not a diabetic. When I am seeing the patient, he is very dyspneic and respiratory rate is 40 and cyano, but no glubbing and no significant lymphadenopathy. Or else I am not able to find anything major other than that of basal fine crabs. So this is a picture. This patient is having this kind of picture for long period around 1.5 years. So when the referee doctor told it is something different, and he told please evaluate. Then the patient came and I have seen the film, and I asked to take a CT chest. CT chest is like that. So he referred as a case of unresolved pneumonia for past 1.5 years. Then I told it is something different, it need evaluation. And the patient was already subject for all the investigation like sputum examination, bronchoscopy and transbronchial biopsy in Chennai. And these are the investigation. Nothing is specific, and FOB was done. It is also giving no positive yield. So it is 1.5 year duration of unresolved pneumonia. So I thought it is something different. We will approach in a different way. We will do some other investigation which will give a clue. So like that, in that mode I am moving with the patient. One day when I asked the patient what is the color of sputum, he told it looks like yellow, and I am producing a lot of sputum. Then I had a little bit doubt. Okay, it is something wrong. You should be very cautious. And I asked them to collect the sputum in a bottle. It is a 2-liter jar. It is a 2-liter jar. It was produced within 6 hours. Okay, something we got clue. So it is a case of bronchoria, and I have proceeded with the transthoracic lung biopsy. It came as a bronchial cell carcinoma. So what is the message I want to convey is even the period of 2 years, malignancy can be one of the main possibility. And bilateral lung involvement is also possible, and it may present from solitary pulmonary nodule to mass, and bronchoria may be the presentation, even though that it is given in around 10%, and it can mimic like a consolidation, one of the important cause of unresolved pneumonia. So simply speaking, it can mimic like anything. Bronchial cell carcinoma is one of the, having variable presentation in pulmonology. So any unresolved pneumonia, I'll just add on to Dr. Piketty's discussion. It may, it is one of case to be considered, and I have already covered that topic also. So this second case, it is a totally different. It is something unusual. Is auto driver of the Damodaran. His complaint is cough with expectoration, blood tinged sputum on and off, loss of appetite and loss of weight, low grade fever on and off for past 2 years. It looks like tuberculosis, and he is revealing history of his having contact with the PTB. Then he told, sir, whether it is possible to have a tuberculosis because my grandfather is also having the disease. Okay, I told possible. Then this is the investigation. The total count is 11,000, and otherwise Mando is negative. Sputum is negative, and malignant cells, fungal smears are all negative. So this is the picture when I saw the patient first time. So it is some amount of non-homogeneous opacities in the right lower zone. Otherwise, I am not able to make out anything. So because he is having a long trunk history, I don't want to take a risk. I asked him to do a CT test. CT test was taken, and it was opined as having the right lower lobe consolidation. You can see that. Otherwise, no mediastinal lymphadenopathy, nothing else. So it was opined as consolidation of right lower lobe, and so because of background of PTB and he is having a long period, I have started ATT. But I am not so happy with the course of illness. There is something we are missing. I am not so happy, and I am not satisfied in justifying the starting of ATT. So I asked him to take X-ray after 5 days. This X-ray, it is a near total clearance. It is something different. We are seeing a lot of patients within a short period of 5 days. It is something unusual to get a clearance of X-ray lesion in a tuberculosis patient. So Yadhartham, I asked the patient whether you had any history of any foreign body aspiration. Then he recollected and told that when I was doing my 10th standard, I have aspirated foreign body, and at the time I have consulted doctor, and he told it is not possible to have in your lung because you are very comfortable. So the patient was reassured, and the patient was living with foreign body, I think so. And because he is also in dynamo, I am also in dynamo. So better to go for bronchoscopy. And bronchoscopy was done. It is one on the tip of pen. Tip of pen is situated very comfortably in the right intermediate bronchi. So I have seen the foreign body. I had a doubt whether we have to touch, because it is long period. It is surrounded by granulation tissue. When I touched the foreign body, he automatically coughed out. I have not done anything at all. Just I have touched the foreign body with the force of. He automatically coughed out the foreign body, and it came out very nicely. So foreign body can remain without much symptom for a long period. So if your case is not, it's not a usual case, please we have to think of some lateral ways, like whether it is possible to have this kind of things. So adult, they are not immune. Adult, they are not immune, and like that, this age group also not immune. So foreign body can remain without much symptom for quite a long period. This patient, this is what is the thing I want to proceed in this case? PFT, because former people used to come and do a lot of PFT in outside, and they will give a report of normal spirometry, severe obstruction, like that. But this case, what I learned, what message I want to convey is a farmer of Thorayur. His main complaint is cough with exertional dyspnea and blood tinged sputum very occasionally. He is not a smoker. So it's the X-ray chest. I have seen the X-ray chest. It is near normal. So I thought it is something. We will go for a PFT. Then we will decide what is the thing to be done. And PFT was done, and the report came as normal spirometry. But see the curve. It is totally different. Even though it is reported as a normal, the curve is not, routine curve. It is something different. It should be like this. So it is a cutoff. It is a total cutoff of a particular level. So it means it is something wrong in the extrathoracic airway obstruction, extrathoracic airway. It may be a fixed or it may be a non-fixed. So CT chest was done with extension up to the CT neck, and CT neck you can see that very clear cut mass lesion at the, just below the glottis, around just below the glottis. So this is the video bronchoscopy was done, and it is showing the very clear cut mass lesion in that area, and biopsy was done. So it is an invasive squamous cell carcinoma. He is not having stridor. He is comfortably sitting in front of me. He is not having stridor at all. His complaint is only during exertion. So this kind of presentations also can come. It is a part and parcel of our practice. We should be very cautious, and in interpreting the PFT, you should be very cautious. So sometimes PFT behaves like a non-invasive endoscopy, and the curves are more important, and dyspnea with the normal X-ray, we should think twice. So it is, we should be very aware of that other than intrathoracic pathology. So this patient is one more different. I recently had this patient of 75 years male of Periyasamy from Arilur. He is referred by one doctor. He is a farmer. His complaint is cough with expectoration, loss of appetite, loss of weight, and low grade fever on and off for first 2 years. And he is not a smoker, alcoholic, not a known diabetic or hypertensive. Patient was referred with the possibility of Cori TB. So I have seen the patient. It looks very nicely, looks like tuberculosis. Looks like tuberculosis. Earlier. It looks like tuberculosis. So I thought we will start ATT. Then I asked the patient to do a sputum examination and all, and patient gone to lab, and that specimen was given to the lab technician. She came and told that, sir, this it looks something different, sir. Please have a look. So I have seen I asked him to transfer to that tube, and I have seen that it is very clear cut green. Okay, something different. Then all the investigations were done, and I asked the microbiologist to do the sputum examination. It came as positive. But what is the color? What is the reason for that color? So I had one case of when I was doing my senior residence in Jipmer, Pondicherry. Like this case, so I asked the patient and I discussed the gastroenterologist. Then we have proceeded with the bile cell bile pigment in the sputum that came as positive. So subsequently, patient was subjected for CT test, and CT test is very clearly opined that intrahepatic lesion. It is invading into the right bronchus and causing the communication. You can see that. Then I asked the patient whether you had any history of surgery for abdominal. Then he revealed that he had undergone some surgery 2 years back for high-rate cyst. Then he brought all the things. I have gone through that. It is very nicely, it is the high-rate cyst. So high-rate cyst was done, operated. Patient was normal in between. Immediately after over 1 month period, patient had some unresolved pneumonia. Patient was evaluated and they have given us some antibiotic. A patient was comfortably doing well, so the patient was discharged. But this picture, after that 2 years of these symptoms is only after that surgery. So retrograde I gone through all the details. I came to conclusion it may be a high-rate cyst rupture into the lung and causing the pyeloptosis. And PTP is a PTP because of pyeloptosis. Patient is going for malnutrition, and it may be the a secondary infection like that. So this is the case. So PTP can come with some other comorbid illness also. So history of surgery for high-rate cyst 2 years back. So green sputum thing of pile also, pyeloptosis may be the culprit for PTP. So this patient I have already worked with Dr. Vellarinson, and this patient is 55 years male. He is a Pudukkottai farmer, not a smoker, not an alcoholic, not a diabetic, hypertensive. His only complaint is when he is going for bed, he is not able to lie down in a supine position. He is getting like a jumping from the bed, but he is comfortably in right lateral or left lateral position. So the patient was admitted for evaluation, and X-ray chest was done. He is not having any chest pain, and X-ray is near normal. But when we see the patient, we asked them to lie down in the bed. He is not able to lie down. He is jumping out. We asked him to lie down for some more time, but he is not able to lie down. He is jumping out. He is much dyspnea. He is not able to lie down, and he is getting restless. So it is something different. It is the case of orthopnea. But what is with this kind of normal X-ray, how it is possible to explain that condition of orthopnea? So the patient was subjected, we had a doubt of something different in the neuromuscular problem, and we have done CT chest, and it was very nicely that report came as thymoma. Looks thymoma. It is not a histological diagnosis, it's a thymoma. So it is the picture. It was there on and off, so it was not permanent. Is ptosis. And one thing, just I have gone through that ICU pearl, that if you are putting the ice cube with some in that eyelid, if it is a myasthenia, that ptosis will be getting corrected. I think you can see that. So it is the thing I have learned from ICU pearl. So the patient is started on anti-myasthenic gravis treatment, and the patient is doing well, and we have discussed about surgery because they are not much willing. So myasthenia gravis causing the bilateral diaphragmatic paralysis is the cause. So orthopnea need not be always cardiac in origin. So that sixth case is just for, because nowadays we are seeing a lot of uncommon diseases also. This patient is Trichy, is a 40 years female of Musria, homemaker, mild cough with external dyspnea of 2 months duration, non-diabetic, non-hypertensive. His blood counts are okay, his meander is negative. Say X-ray chest. X-ray chest is showing very clear cut of bilateral hilar enlargement. Female, CT was done. So you can see that clear cut of node involvement, and patient was subjected for transbronchial lung biopsy. It came as a sarcoid. So we are coming across a lot of cases of sarcoid also. So sarcoidosis is not an uncommon disease, particularly in female. The patient is, is a 22 years male pathology. Is a computer engineer basically. He is from Tindikal. He came as a OPD patient with complaints of cough with mild expectoration, fever on on and off, and left side of pleuritic pain of 15 days duration. He is not a smoker or alcoholic. He is not having any comorbid illness. When he SPO was then SPO is 87% in room here. Pulse rate is 110. I have seen the patient. What is the point I have learned and what is the point I have observed? He is disproportionately dyspneic to the lesion in the X-ray. You can see the X-ray. It is a mild abnormality in the left side. Otherwise, I am not able to make out anything much, which is less. It is very unlikely to explain that amount of dyspnea. So we will admit the patient and we will work it out. And then patient was admitted, and it is CT is showing that left side had pneumonitis changes. Then because he is disproportionately dyspneic, so it is one of the things we have to think of pulmonary embolism. So angio was done and the CT contrast was done. It is very clearly opined as having that thrombus in that major vessel. So treated outside as a community acquired pneumonia. So all consolidation need not to be infective in origin, and we should be very clear in monitoring the patient whether the patient is getting improvement or not. That is the main point, because pulmonary embolism can mimic like anything. It may be from the SPN to consolidation. So that patient was subject for hypercoagulation for a while, and antiphospholipid antibody was done. It came as a positive. Now the patient is under follow-up with the physician. So all consolidation need not to be a infective in origin. And the last case, and Recently, I have seen the patient with the X-ray chest of this. He's a 60 years male of a smoker. Patient was referred for evaluation of dyspnea only. Patient already consulted neurologist for loss of vision, and this is the X-ray chest. It's the X-ray chest. If first sight I am not able to make out anything wrong. But what is the reason for this amount of things? Whether it is we are dealing with something like a malignancy, then I asked the history, then I got taken a CT chest. It came as very clear-cut mass lesion. Even though it is not histologically proved, because they are not willing, because they have spent all the things. So that we have explained the patient need a biopsy and other investigation, but they told because of age and we are not in a position to afford. So patient was not investigated, but most probably this case will be the malignancy. So we are seeing a lot of patients from common to uncommon disease. So we should be aware of uncommon disease also. So these are my observation, and these are some things I have learned. And so thank you. And
I think Dr. GS will take up questions from you. Any doubts in all the pearls? And so the last case, last but when you presented, did he have any DVT?
actually, and that patient